Okay, good morning everyone. Welcome to the Health Partnership Board here in Rochdale. Thank you to Rochdale for the hospitality. We've got a full agenda, so I don't want to spend too long on that, but I was reading this week in the report from Public Health England, and the statistic I kind of think is helpful is the healthy life expectancy figures which came out, and so it says what age on average does a person become dependent upon medical treatments, and the sad thing is in Greater Manchester, 6 boroughs, 6 out of the 10, it's under 60 for men. For women, 5 under 60. We have the worst, two of the worst in the country, so still big challenges, I think, to change that around. Right, nothing else there is to say. We'll go on with the agenda. Can we, any apologies, Lindsay? No, those apologies. And welcome to everyone whose first meeting is today. I hope you enjoy it. Minutes for the 30th of July. Can we just note those? Thank you. And John, please give us an update on.
Right, morning everybody. So just a word really about the agenda this morning. It's deliberately bookended by 2 local presentations, one from Wigan and one from Rochdale. This will be increasingly the pattern at these meetings because we're now in year 3 of our 5-year plan and we're deep into delivery of our transformation programmes, and in particular within communities. And this is a really great forum to share amongst local systems, but also with the public and wider audience, some of the detail of that delivery and what impact it's having. So I'd like to say thank you to Wigan and Rochdale for stepping up this morning, but over the next months we would hope to have presentations actually from all 10 localities in terms of some of the best practice across the patch. Just pulling then from my Chief Officer's report some highlights. I just want to say a word about the work we're doing on our future operating model. It may seem strange that we are having to revise or refresh the way we work under the devolution deal only in the 3rd year of what is a 5-year programme. But there are 3 really critical external drivers that we can't ignore, we don't want to ignore. One is the forthcoming spending review, which we need to speak into in terms of the future shape of our system and what we need from government, from Treasury, but also the departments as well. The second is the development and publication of the 10-year health plan, NHS plan, and also the expected social care green paper. We need to be clear about what shape of system we want in Greater Manchester and try and ensure that some of that percolates those 2 national documents. And then third, and maybe in some ways most immediate, NHS England, the commissioner and investor in NHS services, and NHS Improvement, the regulator of licensed trusts who deliver much of our healthcare in this country. They are coming together, so they are integrating their functions, not statutorily, at least not yet, but certainly structurally and functionally. And that means, amongst other things, that we will have a North West regional office that has NHS Improvement and NHS England under the direction of a single regional director. So if we're going to maintain and enhance the integrity of our devolution deal here in Greater Manchester and the relative autonomy over how we work and how we make decisions, we have to define how we relate to this new combined structure. And that means that we need to take what we've learnt from our accountability agreement with NHS England over the last 2.5 years, which has worked very well, and extend it across to NHS Improvement in some form, so that we have got a clearly defined relationship with the whole of the national system, not just part of it. So that is at the core of our work in developing our operating model. But given we've got to do that, we might as well do some other things as well. So one of the things we want to do is to refresh and restate our value proposition. In other words, why devolution? Why does this work better? By showing evidence of what we've already achieved in the first 2.5 years, but also casting forward in terms of what we confidently believe we will achieve if we're given a further run at this in terms of the next 5-7 year period. We also want to look at a little bit again at our commissioning framework. We did a lot of work on this last year, and we've got a really good plan, but we now need to take that to the next stage in terms of the way that the locality commissioning functions work, and also the relationship between what we do at Greater Manchester level and what we do at locality level. And not exhaustively in terms of the list, we need to work out how we want to relate to the national systems in terms of the finance regime. If you remember back to the original devolution deal, we did a deal really around the delegation of oversight of the system, including financial oversight. We also did a deal around transformation funds. We need to refresh that in the context of the spending review, but there were also two other asks that we made at the time of devolution that never really got answered. One was around social care and social care finance and the current underfunding of the system, and also the model. And the second was capital, where we're still like any other part of the country, and you'll hear this when I talk about estates later in the agenda, in terms of bidding for relatively small pots of money for very particular discrete projects, which makes it very, very difficult to take a medium-term view and to plan across the whole public service estate. And the same is true of digital as well. So we really want to speak into that space in terms of how we would like the GM finance system to work in the next period. So there's a lot of very hard work going on the operating model. We've got a big engagement event for this board on the 2nd of October. So I hope I've whet your appetite and you'll prioritise that. I think it's afternoon. And when we all come together to do some more detailed work on some of the themes I've described and a few of us that I haven't. The next thing I just want to briefly talk about is one element of the work on personalised care. And it's top of my mind, and something I don't think I've ever properly talked about in this forum, partly because I had a really good evening on Monday with the regional council of the British Association of Social Workers, BASWA, and it made a considerable impact on me, and I just want to share a few things about it really. I think that over many years social work has been an undervalued profession. When you look at the complexity of their training and all the different theoretical frameworks that they draw on and the way that they apply that in terms of proactive personalised care when they're allowed to, it is a really powerful force. And we've seen that probably most pertinently recently through our Focus Care programme, where we've embedded social workers into general practice in our most deprived areas. And other districts who don't have Focus Care have their own version of this. And the impact has been really considerable. It brings things like social prescribing really to life because it makes it relational in terms of the way that those social workers can go on a journey with those individuals and help to understand their strengths, who they want to be, what they want to achieve, what they can do in a really strengths-based conversation. And social workers are trained; they know how to do that and how to do it well. But the problem is that over the years, increasingly, we've hamstrung them by basically turning them into reactive case managers whose real job is to gatekeep resources and to basically put in place care packages against the statutory requirements of the Care Act. And that basically is like putting blinkers on a horse. It might run fast, but actually it can't see the whole landscape in terms of what is possible. And so what we need to do in Greater Manchester, in each of our districts, in each of our areas, is to release social workers to be all that they can be, leading multidisciplinary teams, working with other professionals, and playing this deep enabling role in terms of what we call enhanced care management, proactive work over time with individuals in a preventative sort of mindset. So I just wanted to share that with you. It was a great evening, and I think it's really, I share it because I think in many ways social work and personalised care should be synonymous. That this is what social workers have always done actually when they've been allowed to do, it's what they're trained to do. and we have this huge asset in terms of our social work profession in Greater Manchester, and we need to make the most of them. On to system performance. There are 5 areas that really focused on at the present time. They're sort of big ticket items, and they're also the items to a large extent will be judged on nationally through the course of this year under our accountability agreement. The first is reducing non-elective demand. In other words, reducing the demand on our acute hospitals in terms of emergency care. And in many ways, this indicator is a litmus test for Greater Manchester in terms of our transformation programme, because we chose to put 275 million of the 450 million transformation resources into local care models. And the main aim of those local care models is to create a community offer in terms of that preventative care, the early intervention that actually prevents people going into crisis. The reality right now is that we have a differential performance across Greater Manchester in terms of that impact of those programmes on levels of emergency care, the numbers of emergency bed days and the numbers of people having non-elective admissions to hospital. So we're going to have a big focus now and going forward in a quite granular way in terms of working with each of the localities around where is their performance in terms of those key metrics. Do the localities really understand what's driving demand in terms of cohorts, neighbourhoods, etc. And then really doing some deep work to seek to reduce that demand. The second area is around elective care. So this is planned care, and the focus here is on waiting lists. And we have a really simple objective which has been set nationally, which is that by the 1st of April next year, our waiting list will not have grown from 1st of April this year. So in net terms, our waiting list will not have grown. In the context of constrained resources and a constrained workforce and all the non-elective demand, that's a really tough ask. But that is what we've got to do, and that's what we've got to achieve. At month 4, we're slightly off. It's variable across GM, but we're slightly off against that objective. So we've got quite a lot of work to do. The third area is cancer performance. And again, while we're doing better than the rest of England, or on average we're doing better than the rest of England, we are not meeting the key national target around 62 days. So we've got recovery work to do, and again that is focused on particular geographies, which means we need some mutual aid to get that performance back up over time to that core threshold of an 85% rate in terms of the 62-day standard. The fourth area is around mental health, but I want to pick specifically mental health for children and young people. We made a deliberate choice under devolution to prioritise investment in children and young people's mental health. 60% of the additional resource we're putting into mental health is going on children and young people. And I'm very pleased, therefore, to be able to share with you that last year we more than met the national standard around access to mental health services for children and young people. In fact, we almost met next year's target, in other words, the target for March 2019, a year early. But just because we've beaten the average for England and just because we've met our national target, it's not enough. Next month, we hope to be the first place in the country to publish waiting times for children and young people's mental health. And that will be uncomfortable in some ways, but it's an act in transparency. Why should it be the case that we publish those waiting times for adults, but we don't publish them for children and young people? And we now have the mechanism to do that. We've got the data, and therefore we should be transparent. But it will then place emphasis and focus on us to start bringing those waiting times down and deal with unwanted variation across Greater Manchester. And the fifth and final area of performance focus is finance. And I'm pleased to say that at month 4, we are on track against our overall system plan for Greater Manchester. And again, that is no mean feat when you see the prevailing position in the rest of the country, which was published earlier this week by NHS Improvement. So I'd like to say thank you to every CCG, every local authority leader, chief exec, every finance director, trusts as well, of course, and general practice and primary care. This is a collective effort. It really, really is. We know we've still got a lot of hard work to do to drive out the efficiencies that we've said we will do through our plans for the rest of the year, but we've made a really good start. and that's something that provides a firm foundation for everything else we do. I commend the rest of the report to you, particularly the quality section actually, on our focus on nursing within general practice, which is a sometimes neglected area that I'm pleased we now have a really good programme of development for those practice nurses. Thank you.
Okay, thank you, John. Any comments, questions on John's report? Okay, Tom.
Just to endorse what John said about the target operating model, so there's quite a number of us heavily involved in this. There's a series of engagement events throughout September with key boards and key groups, but it's really just to emphasise that opportunity on the 2nd of October for everybody to try and prioritise it in their diary, because that really is our opportunity to help shape GM devolution in phase 2. So I just wanted to endorse that, please.
Just wanted to pick up on what you were saying about social workers, because I was trying to do a bit of work to help the Social Work Academy at Manchester Metropolitan, and one of the barriers they were experiencing, we were trying to encourage them to get their trainee social workers to get out onto placements in VCSE organisations and visits and all that kind of thing, but apparently at national level that isn't recognised. So if they go for a placement in an organisation which isn't some kind of authorised body, it doesn't count towards their training.
Thanks for that. I didn't know that. We could do something about that, because the issue must be about supervision, and there must be a really simple way of squaring that circle in terms of getting the host local authority to provide the supervision but allowing the placement to take place in the voluntary sector organisation. So I'll take that away.
Other comments? If not, thanks, John. So we move on to the presentation from Donna about the service development footprint in Wigan. Donna.
I'm Donna Hall, I'm Chief Exec at Wigan Council, and I'm also Accountable Officer at Wigan Borough CCG. So what I wanted to talk about today is builds on some of the work that we presented to Andy's Public Service Reform Board. Was it last week? I think it was last week, but with more of a health and social care element to it. And what I'm going to talk about isn't really new. I'm sure many of you have got some of the similar kind of setups within your localities. I think what is different about some of the stuff we're doing in Wigan is that we are bringing together in a place-based dimension a lot of the data that we've got already in our systems, but more importantly actually doing something about it in place-based teams. So I'm going to talk about the way we do it, but then I'm also going to show you in a little video, a little film, to kind of bring it to life so that you can see that we're not just making it up. Okay, so basically what we've done is divided Wigan into 7. So we've got a population of about 323,000 people live in Wigan Borough, and we've divided our borough up into 7, what we call service delivery footprints. I don't like that term, but they are place-based teams of people working in an integrated way, and they are populations of between 30 to 50,000, which all the international evidence says is the best footprint geographically to do this work. So if you remember, I think we presented this about a year ago. Will Blandamer from Wigan presented this to this board, and I think this is just an explanation of how far we've evolved this work since the last time you saw it. So basically we've got 3 major boards in Wigan. We've got a Public Service Reform Board, we've got the Healthier Wigan Partnership, and we've got the Wigan Education Partnership. But what brings them together is those 7 service delivery footprints and the common principles of working that we've outlined at the top there. So it's about knowledge of the community, some of the things that John's just mentioned about social workers, absolutely critical that social workers are embedded in these place-based teams. Working together in an asset-based way and sharing an understanding of who is the most vulnerable in our communities and most at risk of all sorts of factors, life factors. And finally, I think really connecting people into community and voluntary organisations that doesn't happen systematically in health and social care. But for me, the place is the way that all of these things come together. And the Healthy Wigan Partnership is our integrated care organisation. And it isn't the privatised thing that is on that leaflet that we were all handed on the way in at all. It's the opposite of that. It's very community based and very much based on public ethos. Okay, so how do we actually identify residents from the 323,000 people that live in Wigan Borough? How do we actually proactively target individuals? So basically, we've got a lot of knowledge within our systems, mainly within the public servants who work in those places, and they are underutilised. So people like teaching assistants within schools, we don't kind of use their knowledge, but they have so much knowledge about families and about individuals. So let's really glean that knowledge and utilise it. We did something called a perfect week, which is we stole from health actually in a school, and we just suspended the rules in a primary and a secondary school for a week just to see what would happen around things like CAMS and access to health services, and we saw some amazing results. Housing repair staffs, they're going into 22,000 properties, and they're seeing families in all sorts of crises, but they're not doing anything with that information, or they weren't until we brought in the Eyes and Ears programme. And also, really importantly for me, the community capacity that we've got. We funded, Peter funded, put 10 million into 500 community grassroots projects that have really helped us shift demand away from public services into much more better connected and better outcomes and cheaper outcomes within community facilities. The systematic use of management information, we kind of have it all separately in different systems, so we don't bring it together and do something proactively about it to prevent things like school readiness not happening across our communities. So basically, these are the things that we have within our systems now. So we can see now who is registered, where they're registered across each of the service delivery footprints, who isn't registered. Maybe a homeless person isn't registered. How do we target that individual? Where does everyone go in a particular service delivery footprint in terms of A&E attendances? Let's try and proactively target where they go. So I'm sorry, colleagues from Bolton, but in Tyldesley and Atherton, 16% come to Bolton. They travel over to Bolton rather than to our hospital. Got Andrew at the back there from our hospital at the back. Looking at disease prevalence, you can break it down by service delivery footprint, the various types of diseases, and you can spot exactly where they are within each practice and proactively do something to prevent that by working with locality teams that comprise GPs, social workers, drug and alcohol workers, community workers and housing workers, benefits people, all sorts of people working in a team. And you'll see that happening, as I'm sure it's happening elsewhere within your localities. Some of the great work we've done with our colleagues in health is to try to target unplanned hospital admission and look at where that is happening. And we came up with about 4,000 people who were at risk of unplanned hospital admission. We targeted it down, mainly people in the 45 to 55 age category. People thought it would be frail elderly, but it wasn't, and really proactively targeted those people through the GP practice with preventative work, which meant that we saw a 30% reduction in admissions, unplanned admissions within that cohort. So it can be done. You can see as well, these are the 7 service delivery footprints at the bottom there. Lee on the left there, Andy, so keep your eye on Lee. But you can see where they're referring people to. So you'll see that some GP clusters within the service delivery footprints are referring massively to private practice outside of the NHS. And that's where we're really trying to target our savings programme. So QUIP, for those that I don't actually know what it stands for, but it means efficiency savings, quality improvement and efficiency savings. We can actually target it down to a specific GP practice to help work with those GPs to avoid referring to the more expensive options. I know people have patient choice, but there are other ways of trying to encourage people to use a local NHS option and to keep that Wigan pound within Wigan Borough. You can also see where referrals are coming from and the first outpatient appointment. It's a fascinating diagram for me. It shows where we're trying to avoid non-elective admissions, and you can see again by the service delivery footprints at the top there where each of the high cost patients are being referred from. We identified one patient who was a resident of Wigan Borough who'd attended Bolton A&E 127 times in a year. And so through proactive work with the GP practice that he was a member of, a patient of, we managed to avoid that and reduced it down to 2 occasions of turning up at A&E in Bolton. So this work is so essential in terms of addressing the demand that we've got in our systems, as well as saving money. It's improving people's life chances and avoiding premature death. So what we've done basically is used algorithms to identify who the high risk patients are, who the high intensity users are, and focus that down through the place-based team to proactively target them with help and support, whether it's a prescription to go and join a local gym, or whether it's something about a local community organisation that gets them feeling better about themselves and not being dependent on the NHS. So one of the things that we've tried to do, again fitting in with one of Andy's public service reform priorities, and again also one of our local priorities politically, is school readiness. We all know it's the single biggest driver of long-term health, that first 1,000 days that we have, which is a really narrow window. So why don't we use all of the data that we have in our systems to proactively target people who are not going to be ready for school? We know on some occasions those children are born. So let's start to really proactively target, map who they are, where they live, and go out and see them and help them even before the baby's born. So I'd like to show you a little film, if it's okay. Lindsay, if we can get that film sorted. Just to let you know, don't worry, this is a fictitious person that these people are talking about. You'll see police officers, you'll see people who work in our hospital, you'll see people who work in our GP practice, you'll see social workers, drug and alcohol workers, you'll see community activists, all working together to help people. And it's Lee, so there you go.
Yeah, I've got a case. One guy bumped into him in Lee Town Centre on Friday. He's sleeping rock in the Broadway's Common doorway. Sean Cook, date of birth 15th 1980. Sean is ex-army. He's got ex-partner, Susan, 3 children. Deputy Sam and Jason, obviously got issues, which is what pressure on his family life. So I brought him today to get some hospital services and see what can be about it.
Right, so I checked on the system, he has recently missed an appointment at the job centre, so I've got a message across to the work coach, and I will be speaking to him when I go in next time, just to ensure that easements can be put in place if they're aware of this current situation.
He has visited A&E 4 times in August, and he's had music with alcohol and issues. With regards to community support, now I'm service for the gentleman in question, there's quite a lot of support for veterans within the locality. The community trust also do a brunch club on a Monday, every Monday at 10:30, which you could go to. We do break people in, it's just a place to meet really and have a chat with each other. We've got that open to us on a conditional caution, restriction like an early intervention. So what we're doing is at the minute we're working with one of our early intervention justice workers, and they're going to be working with that in order to try and curb this behaviour. So what we need to do is just try and get back through that prevention, and then hopefully we'll continue to engage with the voluntary.
The children are registered in practice, chasing them up of independent organisations. So,
Right, I've had a look at our housing system and it's not currently on schools, but with the main homes it's important for the GP, things like a chat so we can look at what housing options are available to it.
Well, he's had more private work on that sort of engagement, and from what you said, there's a lot of support available for it. And engagement's sort of a bit of a problem, maybe. Not that we'll get to spend a bit of time and kind of challenge and see what he wants, and what sort of options he
don't raise 50 anything, but you want to nip out after the meeting and take around where you can sleep in.
Yeah, no worries. I'll chat after this.
Right, so let me just recap some of the actions from today then. So, negative complex pregnancy, I'm going to act as key worker, pick Sean up, and I'm going to go out and do a joint visit with Barry after the meeting. They told me to run through housing assessment. And finally, future workers, they introduce more next week. Brilliant, thank you very much everybody. Don't forget to keep talking in between, and we'll do a catch up next week. So thank you very much for everybody. Thank you. I'm 26, lived in Hollingworth for about 13 years now. Was my parents' previous one. The person from away was to come back home. Classroom with parents, it was a bit of a rocky road. I had mental health issues, did some silly things with myself. I couldn't find a light at the end of the tunnel. I thought, when I moved back home, I knew that I'd be getting a prison run eventually, but I didn't think that I'd ever would for a few years. I was arguing with mum and dad all the time. It just went in a very good place, and then when the mental health weren't getting any better, if anything was getting worse. I realised after a bit that I needed some help, and I went to the hospital and asked for that straight away, and took me in with a huddle. And then before I knew it, I got off the flat. And since the flat, I've been in there 6 months now, and I've just gone from strength to strength. The confidence has come up. The life was totally good there, thinking about before that, but now, got the independence and learning to manage my own money, getting on a hell of a lot better with mum and dad, and that's what means the most to me. I'm 26 years old and I'm finally acting like it. I've got everything and everything's coming together. And here in the voluntary place, they've noticed the difference in the last 6 months. And the confidence has come up and how I'm more outgoing. I don't have to wear headphones anymore. The anxiety, the depression, the letters are not there. I'm closer to getting diagnosis, to learning, to putting I can see a light how everything's coming together. Before the huddle, before I knew about the huddle, it was just like I was another statistic and I worked as an individual. Whereas when Elaine came into everything, she treated me as an individual, and not every candidate is the same. It's like everybody's different, everyone has different circumstances, everyone has different needs. And she didn't just think of me, oh, another candidate to get into housing. She thought of me as somebody here needs my help and I'm going to do the best. And I couldn't ask for a better life right now.
Apologies to people who've seen that twice, but it's so simple and yet so profound. It's basically just wrapping services around individuals and helping them achieve what they want to achieve. The huddle is not the totality of place-based working, it's just one way of connecting services around individuals. So hope it's been interesting. Thank you.
Thank you, Donna. Any questions, comments on the presentation? Andrew?
Yeah, it's Andrew Foster, Chief Executive of the hospital in Wigan. I want to endorse that excellent presentation as being not only the reality in Wigan, but as far as I can see, this is about the best possible strategy for demand management that we can possibly have. And this goes back to John's point in the performance review. The first measure was about looking at the effectiveness of demand management. And so far, the hospital has been largely a recipient of this good work in terms of keeping people out of our doors. But I think what we want to do is see how we can contribute more to the programme. For example, putting geriatricians into care homes, because one of the big learnings from last winter is that the significant surge in activity that we all saw was in the frail elderly. So using this approach to direct care around the frail elderly with care plans for those is probably going to be one of the best things we can do this winter. I'm also interested and have been talking to Donna about how we can go even further and faster with all this, and the opportunities really seem to be about using some of the most sophisticated IT systems which can collect huge amounts of data. I mean, Donna talked about the data that teaching assistants and home workers have. Well, of course, hospitals have vast amounts of data as well, and healthcare assistants and many others. And that, you know, by integrating all this data, putting it into a data warehouse and using the most sophisticated IT systems, you can then create a case management approach which will literally focus the attention of the relevant care worker onto the needs of the individuals who are segmented, not just into multiple users of hospitals or frail elderly, but diabetics or people with mental health needs as well. So I think this is the way of the future.
Thanks, Peter. It's Wigan and Lee takeover this morning, I think. We had the presentation to the Reform Board last week, and I said to Donna that, for those who were there will remember, that the one thing we were going to agree to was to pay for some acting classes for the Lee huddle. We thought there was need of some help there, I thought, but anyway. I just want to say something actually that maybe provides a bit of context to what you just saw. It was about 2008, probably a bit earlier actually, Peter will remember. I was approached by a group of primary head teachers in Lee who said to me that they just couldn't raise their SAT scores above a certain level because of the number of kids coming to school without basic language and social development. And it was through the old Lee Education Action Zone, if Peter remembers, and we began a project called the Lee Parenting Project, where the primary schools were saying, put us in contact with the health visitors and social workers and let us start working with the kids from age 2. And we got some way with it, but it all collapsed, and I have to say it collapsed because of health. The health visitors just didn't go to the meetings, it just didn't work, the partnership just wasn't, I think maybe we were too early with it in some ways, but it may explain to you why some of the things that we're doing in public service reform, that was a big thing really for me in terms of trying to understand why things don't work. And I think for the council as well, as then it went forward and all the incredible work that Peter and Donna have brought through around the deal. And I think we're kind of coming back stronger actually, having sort of learned from some of those things. And it really strikes me, and it brings over, this is the model, isn't it? Because that conversation we heard is touching on homelessness, it's touching on school readiness, life readiness of the young teenagers in the family. And it's one conversation about all the family, isn't it? And all of the issues. And the second video brought over something as well, which is a recurrent theme at the Reform Board. Names, not numbers. Talk names, don't talk statistics on a page, in terms of A&E or whatever. This is about starting with those people who need our help. So it was a really significant moment for me last week where John, where's John gone? When there was some debate about, do we leave this model quite loose in Greater Manchester, or are we clear about localities, the huddle, and all of these elements of this kind of way of working? And there was a kind of call to keep it maybe a bit looser. But John made an interesting intervention, said, no, we need to make sure this is clear. People can interpret it differently and do it differently in different ways, but what we're trying to do, true place-based working around the individual, around the family, with the voluntary sector in the room as well, it isn't really negotiable. We should be saying that is the Greater Manchester model. For me, having had the experience of health, having not come to the table in 2008, to then hear that, I thought was significant. It's not about imposing anything, because places will do things slightly differently, but I do think we need to make this the Greater Manchester model, the Greater Manchester model of public service delivery. It's person-centred, it's place-based, integrated, and it is about the family and the individual and really helping them deal with all of those challenges that we've set. I would like actually to sort of see if we could really clearly articulate it in a document that we might bring to the Reform Board, because I think John did make the point, and Andrew in some ways has just touched on it. Is it yet understood? Are the hearts and minds with it? We discuss it in this room, and maybe we all feel we know what it is now. But is it really understood out there? And perhaps in the acute sector, do they really? They maybe hear some of this talk, but do they really understand it? And are they really part of it? And I think that's possibly where we need to go now into the next phase. But for me, last week's Reform Board I felt was a significant moment. It possibly was the end of the beginning, and then the start of a real phase of deepening integration all over Greater Manchester. And I just thought I would kind of report back on that, and let's get those acting lessons sorted out, because that was a pretty wooden performance. But I think it's very, very exciting, and I think this is the basis really on which I think we should be working.
I just wanted to endorse it as well, because even though this is really valuable for patients and citizens in terms of life outcomes working in this way, it's really valuable for the workforce. And we often don't reflect on that. So general practice, for example, have really want to do the right thing, but often feel really deeply isolated. They're not exposed to some of the figures and some of the problems and how known their registered population are, or parts of them with other sectors. So this is of deep value in terms of not just the life outcomes of people, but actually our workforce, that they have a way to communicate the needs and hand over to someone who can do something readily about it. So I would totally endorse this. How we go forward and make it happen is something for discussion, but really this principle that's happening in Wigan and some other localities is really what we want to be producing in GM.
Thanks, Peter. Following on from that, I think it was a really good presentation and actually gives some food for thought as we go into our discussions around future target operating models as well, in terms of what we can do at Greater Manchester to see something that gets that balance between, I think, enabling and enforcing in a sense. And I would welcome the opportunity to have more kinds of discussions like this about what's frankly working well and what needs to be developed in each of our localities, and how we can then use that to help each other across GM.
Bev just triggered something actually, because I think the one thing that is going to maybe hold us back is DWP. I went to the Platt Bridge place-based team once, and it was brilliant to watch them working similarly to what we saw in the video. But what they said was, one of us will do all this great work, then one of us will have 3 hours on the phone to the DWP. And I just think, Peter, the partnership working with the GMCA, I think we need to start developing a bid for full DWP devolution based on the success of working well, because it has worked well. And I think that should be where we're going here, you know, because you saw on the video the woman said, oh, I'll do what I can to stop them when they go to the job centre getting sanctioned. Well, you know, the DWP team in the region actually are really, they're always at the Reform Board, they are really supportive. You know, they are with us because they see now how, if they're part of this team as well, that is, you know, the bit that stops people going into the crisis that then gets them to the A&E, isn't it? If they can't get the money, the benefit system, that still can mean that all the great work of the huddle falls down because of the DWP decision. And I think it's articulating this clearly as part of the Greater Manchester model. I do think we should be now preparing a bid, maybe for a DWP partnership like this, you know, a partnership with the government, so not full devolution, I don't know. But I do think that a DWP that's empowered to break out of its kind of, you know, its tick box regime and to work with us, I think would be going to the next stage.
Yeah, I completely agree with that, and I think what we've found locally is that despite the national policy setting, the local workers in the DWP really want to make it work, and they will do their best within the existing framework to make it work. Having said that, I think some of the more intransigent bits of the system are actually within councils, within our own workforce. So my biggest challenge, I'll be honest, was children's social care. And until I sorted out the leadership of that area, that was the biggest challenge, because of some of the things that Alex and John said at the beginning about the professional disciplines that children's social workers have. But I completely agree about DWP. And again, Tracy's absolutely right about the staff morale in these teams. They are the most motivated people working across our organisations, because they know each other, they know the community, and they can just get on with helping people. In fact, in Platt Bridge, they've got something written up on the wall that says, don't do anything if it doesn't help a person, because we just keep referring people around the system very expensively and unproductively.
Okay, thanks for those comments. Steve Pleasant and I had a meeting of the social care leads the other week, and I thought, in a sense, that we began to, I think, feel a changing mood, because clearly we understand the pressure that social care is under, but what the meeting was very positive about what was happening in Greater Manchester was really good practice, and how we should, as Bev said, roll that out, not simply keep it because Trafford's doing a brilliant job here. We should find out what they're doing well and pinch it, copy it, if that's the way to go forward. And I thought it was a very positive meeting. I actually slightly disagree with Andy about DWP. I think we should just abolish it. And I advocated that upon time. It actually is, you know, staff could come over, work within our system, we could pay the benefits within the national system, it could all be much more better integrated, and we could really serve people rather than the system. So
I look forward to that speech in the House of Lords soon.
well, I could do it. The other thing which I think people are slightly nervous about this approach, and I can assure them they shouldn't be, is what are the financial implications? We've been doing this in Wigan for a number of years now, and it's enabled us to freeze council tax for 5 years other than the social care element. So in a sense, when you get into this early intervention, prevention work, working with people, working in a different way, it actually isn't more expensive, it saves money. And that's a really important thing about it. So thanks to that, I think we should follow up on this point about, you know, making sure we do get a GM approach on this and really get motoring, because it's, you know, the sooner we do it, the sooner we benefit the number of people around. So thanks again. Okay, we move on to the Memorandum of Understanding between GM Health Innovation Manchester and Health Technology Industry.
Good morning everyone, my name is Arjun Sikand. I'm the Associate Director for Commercial Partnerships at Health Innovation Manchester, and I'm here this morning just to speak about the proposed MOU with the health technology industries and Greater Manchester. I suppose, as we all know, technology is increasingly becoming a more crucial role in everyday life, and it's making more progress in not only maintaining health, preventing illness, managing long-term conditions, but also in curing diseases. So I suppose the MOU really initiated a couple of years ago when GM system leaders met with the associate of the ABHI and their CEO Peter Hollingworth, and they started discussing about how they could work together to co-create new models of working that would include engagement with health technology companies and the health and care system, and also talking about how they could develop and expand into a globally competitive placement, Greater Manchester, for the interconnectedness and generating of first-world, real-world evidence data. We see this MOU as a method to lead to improved outcomes and patient experience. It will also ensure value for money for the NHS and local government, as well as attracting inward investment into the city region, contributing towards economic growth. The MOU is one element which will support the wider ambitions and delivery of innovation into the health and care systems, but it is also just a framework to enable success or to monitor successful partnerships with industry and new models of working. What we would ask of the Health and Care Board system is to be involved in the process of determining and identifying good interventions, good technologies where they could play a transformative role within the health and social care in order to reduce health inequalities and variation of output. And in order to be involved, we would ask for support in facilitating meetings, talking with entrepreneurs and innovators so that they can really get first-hand needs or first-hand evidence of the needs of the system and co-creation of solutions. And also to be involved in the value-based evaluation and adoption of these innovations, which could also lead to economic growth for the city region.
Any questions or comments on that? Are you happy to sign up? Andy?
To welcome this very much, and it's very well timed because of the work we're about to get underway in earnest on the local industrial strategy. I don't know how much colleagues in the room know about that, Peter, but we're one of 3 areas that is working to agree a local industrial strategy with the government by March next year. And over the rest of the autumn and into the new year, there'll be lots of events taking place, consultation on the GM local industrial strategy. And interestingly, a conversation last night with lots of people in the business community. They are saying that health is the thing that is the kind of truly unique thing in terms of Greater Manchester's opportunity, and it's the combination of devolution with the strong digital sector, that puts us in a position, and Health Innovation Manchester, obviously a signatory to this, and all of the work coming out of the university, that puts us in a position where we can be a leader in health innovation globally. And the growing feeling is that this needs to be a kind of front and centre of our local industrial strategy. So I think at some point the Health and Care Partnership needs to kind of really engage, rather than feeling that the business community is writing the local industrial strategy. I think it needs to be, we need to involve people in this room a little more, because obviously the opportunity could be great, couldn't it, if people are coming here as partners to prove new concepts of assisted living or whatever, using artificial intelligence on kind of scanning people's data to create a preventative sort of early warning or whatever it might be. I think we need to really kind of see that there are absolutely economic benefits, but also there could be benefits for our model of care as well. So it's just to flag up that this memorandum actually comes at a crucial time as we prepare the local industrial strategy, and maybe, Peter, at some future meeting it might be important to get some of the team involved in writing it to come here and really take people through the thinking on health and health innovation.
Yeah, thanks. As we signed the original health devolution deal, I think as part of that deal, I think we understood the opportunities that would give us in terms of the economy. So that's why the Health Innovation Board was set up, and which Aaron works for, and is well run by Rowena Burns. So I think we already had the vehicles in order to do that work for us, and obviously make sure it's reported back to the full partnership. So we all agree. Thank you very much, Aaron. Tobacco making smoking history. Carolyn, you're going to start the update.
Thank you very much. Thank you, Chair. So really pleased to be able to kind of co-present this paper this morning. It's actually not that long really since we launched the original strategy back in July last year, and if you just look at the purpose of the report, I think it really, in sort of 3 or 4 lines, really starkly sets out the challenge and the rationale behind this. So smoking remains responsible for around half the difference in life expectancy we see between our poorest and most affluent communities. So one thing that people do to have that kind of impact, and that we're still significantly higher in Greater Manchester in terms of our smoking rates than the England average. And the most, the highest rate of smoking attributable deaths, and the one that's really the killer, isn't it? Literally, smoking will kill at least 1 in 2 of our 393,000 current smokers. So, the case for change is extremely clear. And so the work that we've undertaken to carry out the consultation, really, in testing sort of public perceptions and appetite, really strong response and support for the work that we're doing. So the strategy set out, a really high level of ambition to literally make smoking history, and we've got such strong feedback in terms of the public support for that across a range of areas that we ask questions there. So making smoke-free zones. It's great to see that here as you come into the entrance for this building in Rochdale today, making it very clear actually that the entrance is not the place to be smoking cigarettes, and people really want to see that actually taken out for all our public buildings and other spaces. So feel really that we've reached this tipping point in terms of public support on a range of these issues, and retailers agreeing as well. One of our particular priority areas is about halving the number of women that smoke at the point of delivery, so we want to go down to 6% by 2021. We're an early adopter in Oldham actually of this programme and seeing great results on it. But that whole thing about smoke-free families, involving the Youth Combined Authority as well, to look at smoke-free childhoods, because we know that actually a lot of people start smoking, unfortunately, sort of in their teens and then carry it on to life. So if we can reduce and abolish that actually in terms of smoke-free childhoods, and a smoke-free generation is part of our commitment and ambition. And then the support that we're putting in place really to my photos kind of not kept up with the text there for some reason, but anyway, I'll carry on. More choice and support to empower quitting. So this is now available 7 days a week, which is really important, that when people need the support, it's actually there, and a whole range of things in place. And we're going to hear from Lee shortly in terms of a personal experience, but one of our quit champions. There's also a project, it's really interesting, isn't it? There should be a picture of somebody, so somebody else. But Salford to Stop the Pilots delivered Swap to Stop. So we know that there's been some debate about the role of e-cigarettes, but what we are seeing is it very strongly is supporting people in giving up tobacco smoking. And the results there again on the screen in terms of 4-fold increase in quit attempts and success, 5-fold for the most deprived quintile. So really impressive results there. And in the anniversary of the NHS 70th birthday, this issue about tobacco hiding in plain sight, actually you only have to drive past all of our hospitals to see the number of people just stood outside smoking. Some people even on kind of IV drips with the stand next to them, or in wheelchairs. So actually hospitals ourselves, despite the numbers of people that are admitted to hospital as a result of smoking, there's still places where you can smoke, and the outside staff as well. So Cure launching at MFT with Insure on the 1st of October, and then rolling out next year across all of our hospitals again. So challenging it everywhere that we see it in those most public effect. And this is an amazing graph really in terms of closing the gap, and in a short period really the amount of progress that we're beginning to see. I'll give a mention for Oldham because I don't like to miss an opportunity, but 5.7% reduction. So we've had the biggest reduction in Oldham between 2015 and 2017, really pushing to continue that. So bringing us down to, but we want to more than close the gap. We want to be, leading the country, if not internationally, on this issue. But great to see the progress that we're actually already making. And so now I'm going to hand over to Lee, who's going to tell us some of her story as well. I'm glad the photo changed. That was the video first, yeah. So can you make it work? Press next.
My name's Lee Webber and I live in Timperley. I'm age 55 and I'm a member of Chorlton Running Club. So I smoked for nearly 40 years. I suppose when you're young you just don't think anything's going to happen to you really. I actually gave up smoking on November the 18th, that was 2016. I'd already started doing some exercise, started the running, and then I started getting a bit sore across the top of my back, and I wasn't sure what it was, so I went to the doctors and he said there's no other way to tell you, but they have found a tumour. So obviously in my mind the shock and the horror and feeling frightened and everything was just in absolute shock really, and all I could think about really was my son who lives with me at home. Hospital phone, and he said it's just going to be an operation to either have part of the lung out or the top lobe of the lung. I just cried where I was so relieved, and I just felt that to what that could have been, I just felt that I was very fortunate. Running fills that same space what the cigarettes used to do, and I love it for so many reasons. I love it for the feeling of being free spirit when you're out. If you're feeling a bit stressed or upset, cheesed off, before where it would have been go out the back door and have 3 cigarettes or something, whereas now I think right to go for a run. If I can get from being a smoker to being a runner, I'm sure lots of people can too. Thanks for inviting me here today to share my story with you all. And as you've all just seen on the film, I now have a passion for running and looking after myself instead of smoking cigarettes. Over the last 18 months I've had so many great times with my latest passion now for keeping fit and healthy, and I've achieved things that I never would have dreamt of before. A year ago last May, 15 people joined me on my recovery run after my operation for the Great Manchester Run, which was very emotional, especially because it was only a few days after the tragic terrorist attack as well. And then this left a group of us who became friends, regularly ran together, made up of venture runs and raised over £4,000 for different charities. Consequently, I'm now the proud owner of a medal hanger with 17 medals for running and 2 of them even for half marathons, which I'm very proud of. I work at a special needs primary school where we have a talent show annually, which I'm very passionate about. So this year I chose to get 30 children involved, running circuits over the stage to the outside area and back again to the scene from Rocky, the running scene, which they absolutely loved. I had tried giving up smoking a few times before, but always felt quite miserable after. I honestly used to think the only way I'm going to be able to do this is if they actually stop selling them. So I decided this time that I was going to have to do it in a really big, different way. So after about 2 months of research, reading books, listening to inspiring people, I set about my journey to become free from this addiction. It certainly was a big task and turned into a project, but it was worth every minute and all the effort that I put in. The main thing for starters for me was that I'd come to realise I'd actually brainwashed myself that I enjoyed or needed cigarettes, which got me very intrigued to start thinking that is it only us smokers that get stressed or upset? If the non-smokers don't get stressed or upset, how on earth do they cope? Which is obviously, a good point to get you thinking about. A lot of people can get quite down or depressed when they give up smoking because of the neurotransmitters in the brain being suppressed. So I was advised to start doing things like the running that naturally could get them kick-started again. There were so many things that I had to change, introduce and reflect on. I came across a little blackboard that was for How Many Sleeps Till Santa that was at a special needs school Christmas concert. And soon as I saw it, I just thought that's going to be great for writing down how many days I've not had a cigarette. And today I'm on day 657. I am planning to start a giving up smoking group in the near future to hope to share my journey with other people and hopefully free them from having the addiction too. I would like to say a few words about this fantastic campaign. I've been impressed by how quickly things are happening and what's been achieved so far, but to get the job done and make smoking a horrible but distant memory for future generations, we can't take our foot off the pedal. When I got involved in the Don't Be the One campaign, I hoped my story would inspire people to quit smoking and grab themselves a new lease of life. I'm absolutely delighted that people did try in their tens of thousands and many of those would have succeeded. Now I'm hoping by sharing my story again, it will inspire the people that make the decisions here in Greater Manchester to keep backing us and helping us drive forward and help others to rid themselves of tobacco once and for all. I would like to end by telling you the best 3 things to me personally that have come out of me giving up smoking. The first and biggest one is being free at long last of being a prisoner to Mr. Nicotine. The second, this quitting journey has not all been easy and plain sailing, but to have had lung cancer and still be here, and all I've been able to do in the last 18 months, makes me an extremely lucky person in this world. And with the money I have saved, I have just booked a surprise treat for my son's 21st in October for us to go to New York for Christmas. Thank you all very much for listening to my story, and hope between us all we can continue to make a positive difference to this fantastic campaign.
Okay, thank you very much, Lee, for that inspirational personal story, and congratulations. Okay, next, Caroline. Yep. Anyone wish to make further comment?
Hi, so I'm from Salford and I led the pilot on e-cigs. So it was again just to, obviously we've done the pilot, we've got some great results. We ended up tackling groups that we hadn't previously been, we found very difficult engaging to giving up smoking, but I completely empathise with the lady at the back that actually we don't want to shift those norms that we've managed to actually shift now. So I suppose it was around what is the next steps for GM. Do we have a collective position on this, or is it down to localities on how we take this? Because I think what we don't want to see that gateway into the young people, and the clinical and the public health community are split on this.
So thank you for your comments. Sorry, I didn't catch your name, the lady at the back. As a frontline clinician, I share some of your concerns. So in my 20-year career as a GP, I've seen two things make a real difference to smoking levels. The first was the 2007 ban in public spaces. The second is the introduction of vaping, which is increasingly seen by my patients as an alternative to smoking and as part of smoking cessation. And obviously the Salford pilot is extremely impressive, much higher quit rates than any other interventions that have been available over the last 20 years. But what we don't know is the full safety implications of vaping, and there's been some recent studies at the University of Birmingham only very recently said it targets immune cells in the lungs, which can lead to the same level of damage as you see in COPD. So what we need as frontline clinicians is robust data and evidence from Public Health England. So Public Health England currently states it's less than 5% the harm of smoking, but we're seeing more and more studies coming out to the contrary, and we're also seeing normalisation of vaping because people are seeing it as socially acceptable. So, you know, I'm looking at Public Health England colleagues for guidance here. So, Gillian, I think one of the things we need to do after today is think about how we can get accurate messages out to frontline clinicians so that when people come to us to ask for our advice, we have something sound to say to them.
Thank you. I suppose just echoing on from that, I think we had quite a robust debate at our Health and Wellbeing Board in Manchester around e-cigs, and I think it's fair to say there is a lot of division in opinion out there on where people sit, and I think the point at which we came down on it is that we understand that in terms of harm reduction, there is a discussion to be had there about the use of e-cigs, but it's not reducing harm completely, and it's in some ways quite similar to discussions we have perhaps around public health debates and drug use, around reducing harm rather than eradicating harm, and being very clear on that. The point I was going to make was slightly different. First of all, I was going to thank you for sharing your personal story. I think it was really great to hear from you, and keep up that running. We can only look at you with envy as you're completing those half marathons. The bit that I wanted to touch on briefly was so one of the things, I'm not easily shocked, but one of the things that shocked me probably most recently was in Manchester around our statistics of smokers, and that 49% of people with COPD were still smoking. And I think that, to me, really highlights the need for a much more coherent and joined-up approach, not just in terms of public awareness, but some of the other things that are covered in this paper. So, for example, the rollout of the CURE programme, I think, is a really good step in the right direction around the access to services people will have when they're in acute care. That also leads me on to the point that was referenced around potential opportunities at 3.11, which is around talking about smoke-free spaces and the discussion that we have around mechanisms that we could use for that. Obviously, Manchester City Council is cited in there as being the lead, but to be clear, that would be with and for Greater Manchester, and that we as a whole within the partnership would need to collectively sign up to the notion that that's the direction that we want to travel, and that would be kind of met within a GM context with Manchester taking the lead. So it's a flag that those discussions are indeed ongoing, but it's for and with rather than independently. But to me it makes perfect common sense if we're rolling out high-cost interventions in hospital care, but those people are having to walk through smokers on their way in and their way out, then we're not going to be able to join up the dots in any coherent way.
just to summarise, thank you, very helpful points, and we'll take them into the Population Health Board, particularly on the e-cigarettes. We are looking, obviously, Public Health England in terms of guidance. Interesting, we had a motion from our Youth Council recently at Oldham about the flavourings and the promotion targeted at trying to encourage young people. So there are certainly things that we could do across Greater Manchester to target those aspects. So thank you for the discussion.
To move on to the urgent care improvement plan, I think, Anthony, you're going to take this one.
Yes, thanks, Chair. Anthony Hassel, Chief Officer at Salford and at Trafford at the moment, and I'm just presenting this paper on behalf of the Greater Manchester Urgent and Emergency Care Delivery Board. There's a paper in your packs. I'll assume that you've had an opportunity to read that. Andrew Foster's sitting behind me. He with myself co-chairs the improvement board, and I think that sends a signal, importantly, about how we're trying to approach the challenge of urgent emergency care in a different way this period, by ensuring that we have system leaders absolutely involved in leading this improvement and collaborative effort. So why do we need to get this right? This is really, really obvious, and I don't need to rehearse it for everyone. But some of my own personal experience, some of you will know that I often talk about my mother-in-law, Joan. Luckily, she hasn't been through A&E recently, but my mother, Margaret, who has recently moved to Salford, was actually admitted to Salford Royal on the 2nd of January this year. And while she had fantastic care, it was clearly a very challenging environment in which both patients and families and indeed staff were operating, because just of how busy the department was. And clearly, of course, what that says to us is we must ensure that systems and individuals and teams are working together as hard as they can to make sure those patient experiences are maximised. So what we've done, we've created a Greater Manchester programme, but which really does intend to add value to the work that is going on in localities. It's clear and obvious that it's teams in localities that are the best placed individuals and areas to know how to deliver and to know how to improve. But it's also clear and obvious that there are common challenges and common areas where we can work together to improve and in a very patient-focused way. The other thing that we've absolutely tried to do is to ensure that this is connected strongly to both locality plan improvements, the work that's going on around transformation, and that this feels like this is one plan as opposed to a separate plan around urgent care improvement. And absolutely ensuring that this concept of patient time is the most important currency that we use in health and care. So what we've done is through a strong process of engagement, both with clinicians, frontline teams, as to what would add value, we've identified 4 work streams that we're now running with at a Greater Manchester level. And these are work streams where we've identified that operating at a Greater Manchester level, learning at a Greater Manchester level, collaborating at a Greater Manchester level, we can really help individual locality systems to improve. And so under each of the 4 work streams, we have identified a number of areas, and particularly what we're trying to do here is identify best practice in localities. So, for example, we know in Stockport and Trafford, really strong uptake of flu vaccination. How have they done that? Where can other localities learn? Bolton doing some really interesting stuff around supporting nursing and residential care homes. Wigan and Bury doing some fantastic stuff around patient flow and improving that. And in Salford, some really strong work around discharge and recovery. So how do we ensure that each locality is learning from the best of each other locality and driving that forward? And you will have heard again me say this, but one of the things that we want to be really clear is, does this programme pass the Ronseal test? Does it do what it says on the tin? How does it do? Is it delivering the improvements that we need it to across our systems? We know and expect that the winter will be a challenging period, and indeed many would argue that we now have a year-round winter. So what we are wanting to do is to ensure that we collect data that is sensible data, that is data that's already collected, so we're not looking for new data, that enables us to measure and inform how our systems are operating, and indeed, where possible, to predict challenges in systems. So just a couple of examples there of the data that we'll use. And then how are we driving this? As I started this presentation, this is all about this being led from the system with strong clinical and officer engagement from all different parts of the urgent and care system, and absolutely connecting into those locality-based transformation plans, but also accessing that improvement expertise that we have available at a Greater Manchester level to give us that professional advice and guidance. So, in terms of next steps, we know that the next period will be a challenge. Clearly, it's important that the improvement programmes that we have in play start to have an impact at a locality level in terms of the improvement needed. I'm confident we have all parts of the system engaged, but also that we are adopting a clear improvement focus. Indeed, Andrew and I will be present at a system development workshop that we're holding this afternoon in Salford, where all parts of Greater Manchester system are coming together to ensure that we're aligned on this work programme. Thank you.
Andrew, do you want to comment?
Just 2 points to support what Anthony has said. I think that this is a very well structured programme this year, and there has been a huge amount of learning from each other, and it actually exactly matches onto the national programme for improving action on A&E this year as well. The feature of A&E is that the metric is the performance within the A&E department, but actually that is the product of how a whole system works. And the two things that I want to say in addition to Anthony's is that we have quite a focus on A&E delivery boards. Each locality has an A&E delivery board which is managing the entire system. And we want these A&E delivery boards to be as effective as possible, which means taking ownership of the problem as a system one, which means having the right people on it, having all the agencies represented, and concentrating the attention of that board at the right level. And that's what this afternoon's workshop is substantially about. So that's that point. The other point is what happens during times when things are difficult. And those of you, well, many will know that from January to March this year was some of the toughest times we've ever seen in A&E departments. And I think we have to be very careful about the interventions that take place during those times. Certainly issues like data collection and requirements for reports are something that have to be handled very sensitively when the people that will be providing that data and managing the situation are as pulled out as they were last winter. So that again is something that the board will be looking at this afternoon.
Terrific. So what you've been doing on that obviously seems good, and fingers crossed for the coming months. Moving on then to estate strategy. You take that from there, John.
And we did have some slides, but to save time, I'm actually not going to use slides. I'm going to just speak to the item. But before I do, I actually just want to interrupt the agenda to do an advert. Because I should have done this in my Chief Officer's report. I meant to, and it slipped my mind. But today, James Frith, MP, is publishing a really important report, and it's a really good report as well, called Living Well and Dying Well. And it's basically about hospice care. And it speaks really about Greater Manchester and the provision and use of hospices within Greater Manchester. But actually, I think it's got implications for the whole country in terms of the role of hospices within our palliative and end-of-life pathways. And the report will be launched today, and it's already available on social media, and it makes a whole set findings and recommendations. I think it's brilliant that a local MP has stepped up in this way and done this almost in extracurricular piece of activity to such a deep level. And the findings and recommendations deserve to be taken very seriously, and we will take them seriously and respond to them in due course. But I just wanted to bring that to your attention. So back then to the agenda item. I don't know how many of you have been watching the Great British Bake Off so far. If you haven't, then bear with us, because some of us are still recovering from the tension of Bread Week. No spoilers. No spoilers. For those who are watching on catch-up, the bread is still rising. But there's a character on it. One of the contestants called Rahul. And Rahul's amazing. It's worth watching the programme, actually, just to watch Rahul, because I've never come across anybody who's quite so pessimistic about everything, and yet he's a genius chef. But the danger of this item, and the reason I make the analogy, is that there's a danger of coming across as very, very pessimistic with respect to the state of our estate and the amount of work that needs to be done. And I wouldn't want to lose in that, because I do need to be realistic with you, the fact that we are also very determined to have a really great plan of how we're going to make progress in terms of improving that estate as well. We'll bring this item here today because we were asked, every STP, Sustainability and Transformation Planning area in the country, was asked to develop and submit an estate strategy to the national bodies and to government, which placed us in a bit of an odd position because we already had one. Under devolution, we'd already prepared one bottom up from our 10 localities some 18 months ago. So anyway, we took the opportunity to refresh it, which was not a bad thing to do, and to make sure that it was up to date, fit for purpose, and could underpin our bidding processes for individual pots of money to deal with individual project requirements. I think there are some things that are very distinct about how we think about estate in Greater Manchester compared particularly to the rest of the NHS. The first is we do genuinely take a whole public service estate perspective. So we don't just think about the health estate in isolation, not least because actually many of the buildings, particularly those in the community, are multi-use anyway, and so they should be in terms of the integration of services and the alignment. But the second is that we do genuinely build our estates plans and strategies bottom up. So we have 10 locality estate plans, 10 locality estate boards that are doing that coalescing at the local level, and then obviously we need to make sense of that at a Greater Manchester as well. Which brings me to my sort of Rahul point, which is that the reality is that when we took charge in 2016, part of taking charge in terms of our legacy was of an estate that has been, well, grossly underinvested in over the last decades. And moreover, there is a variation, which means that the estate which is in the poorest condition is in our poorest communities. Now, we might ask ourselves, how on earth did that happen, over those decades? How did we collectively end up in a position where, particularly in terms of our NHS estate, the estate which is in the areas that suffer from the worst health and have the most need for those services have got the worst estate? And that is concentrated, not exclusively, but significantly in the estate of Pennine Acute NHS Trust. And I'm not going into the detail of that today, but I state that as a matter of fact. So the reality is that we have a large backlog in terms of routine maintenance and repairs that we inherited, and we have a major need for replacement and upgrade of a whole range of buildings, both within the community and within the acute estate. We're also, it has to be said, hamstrung to some extent by the way that the health estate has been developed over the last 2 decades, and not least through the use of private finance mechanisms, PFI, LIFT, which ties us in to particular long-term deals, which can make it more difficult to actually flex the way that we use buildings and organise services for the best benefit of patients. But that is our legacy. We own it, and we have to accept and make use of the asset that we do have and the constraints in terms of we're operating under. Within that context, we take a very flexible approach to capital financing. One of the benefits of being a partnership is we can think about what everybody can bring to the table: government, central government, local government, combined authority within that, obviously the NHS itself, not least through the trusts, and within that particular freedoms around the foundation trusts. But the bottom line is that if you look at our need for resource, there will always be a significant reliance on public service capital. And one of our asks of government, which will be embedded within our target operating model ask, is that we should be given more freedom around how we use public service capital. So instead of having to bid for every individual project and that being decided in Whitehall, that actually we should be given our pro rata share of capital resource going forward and should have our own ability to determine the best way to use that and to combine it with other funding sources with respect to one public service estate. There are needs at community level in terms of our integrated care model. There are needs at the acute level, and we're doing master planning at most of our sites to make sense of our legacy. And there are particular opportunities around our mental health estate in terms of dealing with buildings which are really beyond fitness for use, but also consolidating some of our offer into better buildings, better campuses, better service opportunities. In all of this, as we go forward, we need to be mindful about what the population want and what they need. And we should be driven really by two main objectives. One is improved outcomes for people, particularly clinical outcomes and benefits. And the second is the ability to actually get to those services, in other words, travel, and particularly thinking of those who do not drive and are reliant on public transport or may have mobility restrictions. We also need to get our own house in order. We can utilise our estate better. Our utilisation rates are not as good as they should be by some distance, and we need to make sure that we are making the most of our buildings. The second is that where we can release land, we should do so, not least because we can use it to build homes. And they could be key worker homes, they could be affordable homes, they could be new supported housing, they could be intermediate care facilities. And we can potentially bring that to the party. So I hope that's a useful summary of where we are. I think we've got a good plan, a good strategy. I can't say hand on heart that we know how all of it's going to be funded right now, but we know what we would like to do. We know roughly the order in which we'd like to do it, and that's a good place to be.
Thank you, John. Any questions, comments on that?
Thank you, Peter, and thank you, John. Very comprehensive update. Just want to come back to your comments about the lift estate, and I recognise the point you made about the contractual difficulties. But I'm kind of guessing here, but I think it's probably not far wrong that average utilisation of lift buildings across GM probably runs about 60%, maybe 70%. Some better than others, but there is capacity there. It is modern public estate, and it's in the heart of communities. And actually, it's a place where huddles, the place-based teams, should really, it's an obvious location, isn't it, for that work. I just wonder, is there something we could do to either buy out some of those contracts, or as they expire, have a policy where we increasingly bring that estate in to the public realm. I just think it is. Some of it was built, I think, from memory, about 15 years ago, in the early part of the last decade, and maybe some of the not as long as PFI contracts. Some of them may be expiring. Is there a case for a bit of a piece of GM-wide work? Is it Partnerships for Health? I think they were involved, weren't they, as well, to see if there is a deal to be done, maybe on not on a case by case, but more if there's similar players working in all 10 boroughs, maybe there's a conversation that we can have a scale rather than an individual building level. I just think it's an issue that is something that at some point we need a better solution, I think, than the one we've got. and actually, if we did manage to gain control of some of those buildings, there is an efficiency opportunity there, isn't there, by consolidating people within those places. So I think it's something I've kind of kept thinking about and wonder whether the scope for a wider GM-wide solution.
So first of all, we would share your ambition. We would like to get control of those buildings in terms of being able to use the estate more flexibly. I've sent your office a technical note as to why that is so difficult at the present time, and it is to do, without going into the great detail, it's to do with the way that the lift contracts were set up and the use of swaps as a financial instrument in terms of underpinning those deals, and basically related actually to the financial crash 10 years ago, it has become prohibitively expensive to buy out those deals in terms of justifying it on a value for money basis. In other words, the swap has gone in the wrong direction in terms of anybody looking to buy those contracts out. I'm very happy to make that technical note more widely available. There's no secrecy around it. But I think we need to do two things. One is watch very carefully to see if at any point those market conditions change and it becomes a more affordable proposition. And the second is, as you've already said, is as those deals come to an end in terms of the period, make sure that our relationships with Partnerships for Health and others are such that we get the right outcome at that point.
Any further comments on John's report? For the stark information, you said that the worst buildings are in the areas of highest need. It's something obviously that we will need to address. Okay, thanks again, John. So then we move on to our final item, which is Rochdale story. Who's going to start?
Thank you. Hello, I'm Karen Kenton. I'm the Associate Director of Commissioning across Health and Care here in Rochdale. And what I'm going to give you just now, I'm conscious of time, so it'll be a very quick snapshot of some of our transformation schemes here in the borough and some of the emerging evidence of impact that we're having. So what we really, when we think about transformation, we often think about really, really big things, big system change. And up there, you've got a couple of diagrams I'm going to talk to you quickly around family services model, which is some of our transformation schemes around children and young people, and then our easy hubs, which is the purple bit. What we really quickly realised, and being the home of cooperation in Rochdale, no charge, that the things that drive transformation are often the little things, and I think Donna from Wigan's already alluded to this, and it's much more around how we cooperate and connect that's going to lead us to improving outcomes across the borough. So these are just a few examples of things that are happening in the borough. So our heat car, so basically that's a car that instead of when the call goes into MWAT, instead of an ambulance response, it's a car that's staffed by advanced nurse practitioners and emergency medical technicians, and those calls will be triaged and an appropriate car will be sent out. There's a quick scenario there for you of how that's working. In terms of early impact, we're seeing 71% of those calls don't then go into attend emergency care department, and 24% of those avoid a non-elective admission. So some really encouraging deflections there. Primary care focused care workers are folk that are based in 32 out of our 36 GP practices, and they're really offering an enhanced support to our GPs to manage those complex patients whose needs are often not necessarily health related but have got a multitude of social wider determinants of health. And since April, around 384 people have been supported in that way to really improve the capacity that we've got in primary care and to free up some of our GPs' times to focus on the patients that they really do need to focus on. Our easy hubs, these are some of the problems we were trying to face, and it won't be, Rochdale will be no different. What our residents were telling us, and our workforce, that the system is really difficult to navigate. There's far too many entry points, there's loads of information and advice, it's not cohesive, it's not come together. The solution is obviously face-to-face access, and a single point of access that the general population and our workers know where to go to, with the big focus on solving some of these big goals that we think are critical to why people fly around the system. So connectors provide information, advice and signposting across the whole system, so voluntary community sector as well as some of our more statutory provision. They are based in each of our townships, through one of our live centres in one of our areas. Some of the real learning, our community connectors, we've got 12, did I say 8 or 12? But they were all recruited from the local community and are all people that have got real life experience and have experienced some degree of adversity in whatever, throughout their life, so can really connect with people and have a lot of credibility with our service users. They've been up and running since May, and so far have supported 450 people to access a vast raft of services across the borough. And the bottom square in the screen is our One Rochdale, which is a integrated services directory across the borough, so that they're helping local residents to navigate that system and to use that system in terms of finding help themselves, and then also supporting those residents to take them to services until they feel confident and resilient in doing that themselves. We recognised as part of our transformation that we can't transform the system without really focusing our children and young people, because we need to start to turn the tap off at future needs in the years. This is just a quick diagram for you. We've implemented a whole model of transformation. So the green bit is more our community and universal services. The bit in the middle, 4 early help locality teams that bring together, it's got a small enabling team, but really do bring together the vast raft of professionals in each of those localities, health visitors, school nurses, your children's centres, your schools, youth workers, police, etc., to provide a really comprehensive early help offer. And then a step up into a complex early help and safeguarding hub, which is built on our existing safeguarding hub to make sure that the police, mental health practitioners, adult services, as well as social care are in there that can provide an all-round risk management assessment. The ultimate aim of this is to keep children out of the social care system ultimately and to avoid them becoming looked after, but also with a focus, the second element, paediatric nurse practitioners, on keeping children out of the hospital system. Big element of this is to change the culture and practice of the workforce, because we think that's where the biggest change is, to really avoid some of the handoffs that happen in the system now, so people are spotting a problem and acting on it rather than referring it on through the system. Some early impact, the locality teams we launched them in January, really got up and running from April, but some really encouraging signs. So the figures speak for themselves really. So we're using early help assessments as a real key indicator to how we're identifying children's needs much more easily. So the figures there to April to August this year, doubling the number of early help assessments that we managed to achieve last year, and significantly more than the numbers that we achieved the year before. We're not quite yet seeing that reducing in contacts into social care, and we're doing some work to start to track these children now to see what else we need to do. In terms of A&E, our paediatric nurse practitioners are hooked into each of the early help locality hubs, so they can really use that intelligence, find out the frequent flyers and get some information off the ground so we can do targeted interventions with those people. Really encouraging this. I mean, it's small, but in terms of our A&E attendances for this cohort in the last year, there was only a 1% rise. It is a rise, but it's almost a plateauing, and it was the smallest rise in A&E attendances for any of our age cohorts in the borough, which again is really encouraging. Just up there, this is, as I said at the beginning, a lot of it is around the softer impact and the culture and behaviour of the workforce. And these are just a couple of quotes that you can read for yourself with some feedback that we're getting from professionals, from schools and our school nursing, around how it's starting to feel differently and how practitioners really feel they're being able to make a real difference. That's it in a nutshell. I said it'd be quick.
Well, thank you very much. And interesting what similarities there were with what you were saying and what Donna was saying earlier. Okay, any comments and questions on the excellent work being done here in Rochdale? We've been exhausted. Thank you again for the presentation and congratulations on what you're doing. The final item is to note the date of the next meeting, which is the 9th of November, but in doing so I need to point out that one of our members, Stuart North, won't be able to be at that meeting because by then he'll have retired. Stuart's been active really since devolution began, in fact really before devolution began. He's put a lot of work in, he's attended lots of meetings, and I think we should record, Stuart, our appreciation of your contribution to GM devolution and wish you well in your retirement.